So I mentioned that we can not only monitor during therapy, but also after the end of therapy. This allows monitoring of the tumor burden and the tumor activity after the end of a therapy, and again, might provide an additional tool for optimized and personalized therapy. So this is a patient who was diagnosed with a triple negative tumor, a small tumor, and she received surgery and then adjuvant chemotherapy and radiotherapy, all of which we did not monitor. And since 12/21, she is under complementary therapy. During the complementary therapy, the number of CTCs and CSCs was monitored regularly. There was a small increase in circulating stem cells, which we can't interpret yet, but the patient remains in full remission, relatively stable cell numbers, and we are supervising the patient continuously. This is another patient who had an estrogen receptor positive tumor. She received surgery and adjuvant chemotherapy, which we also did not monitor. But since February 22 until current, she receives exemestane and complementary therapy. And we can see that there is decrease, even a little bit sawtooth, but still decrease of circulating epithelial cells and circulating stem cells. So the patient remains until now in full remission. Do you have any questions about these cases?
May I ask, do you have any particular concern about which number or amount of cancer stem cells in the stemtrac are of concern?
We have shown in our publication that patients with metastasis have stem cell counts above 300. So we think below 350 stem cells or in this area are not really of concern. So we think there is a threshold where we can say, yes, if there is more than 300 stem cells, the therapist should look with other imaging methods whether there are metastases present.
Thank you. There's one question. Any research or experience on natural therapies post-surgery, such as curcumin and darts and detoxification, and the outcomes?
Well, we can't globally tell about whether the naturopathic treatments are effective. We need to see, and indeed, yes, we can see under curcumin treatment, for example, a decrease also in circulating stem cells. But this remains done for the individual patient, whether the therapy is effective. And we think that the tumor stem cells allow to assess the residual tumor aggressiveness and the risk of metastasis, as you just mentioned. And this is shown also in this case where there was a patient with, again, estrogen receptor positive tumor who received surgery and subsequent adjuvant chemotherapy. And then we measured the cell numbers under this adjuvant therapy. There was little change in numbers, which means that there is no increase in cell numbers and the stem cells remained very low. But the question is whether this therapy has been really effective. And subsequently, after the end of the therapy, there was a low number of circulating stem cells, no changes in the circulating epithelial cells, and under tamoxifen, now numbers decrease. So we think this is a sign of effective treatment, and the patient until now remains in full remission. In contrast, this was another case with a 59-year-old woman diagnosed with endometrial cancer. She was treated surgically before we analyzed her, and she remained 5 years relapse-free. But then she relapsed in 2019 with lung metastases, which were removed by surgery, and subsequently received chemotherapy, paclitaxel, and carboplatin. And here we could show that there was a nice decrease in circulating cancer cells. At that time, stem cells were not analyzed yet. But then, after the end of this chemotherapy, circulating cells as well as stem cells re-increased before liver metastases were detected. And although the checkpoint inhibitor treatment led to a decrease, the metastasis in the liver increased in size. But subsequently, she received again chemotherapy, and cell numbers and stem cell numbers decreased. And she was in remission. But again, her cell numbers and her stem cell numbers re-increased, preceding new liver metastases and the progression of these new liver metastases. So the level of cancer stem cells increased significantly each time before disease progression, together with the circulating cells. The patient is now again under treatment. Here again, this was now not breast cancer, but metastatic colon cancer with a KRAS mutation. And he received FOLFIRINOX and complementary therapy. He had a very good clinical response, and we can also see a decrease in circulating cells. At the end of therapy, no circulating cancer stem cells. He then had surgery and for quite some times remained in remission, but due to the increase in circulating cells and cancer cells, there was a PET-CT performed showing recurrence in the liver. So in this case, the PET-CT was performed due to the increasing numbers of cells and showed the relapse. After the recurrence in the liver was removed by surgery, cell numbers re-decreased, stem cells re-decreased. It's not clear whether this re-increase in the circulating cells is a sign of imminent recurrence, but we are monitoring this patient further. And we had been talking about no CTCs detectable. And in this case, we can look for circulating cancer stem cells. This is shown here in a patient who had metastatic lung cancer, quite large. She had chemotherapy before we analyzed her. She had radiotherapy of a brain metastasis. She had change in therapy with a checkpoint inhibitor. She had quite some time stable disease, but due to this stable disease, the checkpoint inhibitor pembrolizumab was discontinued, and we did not find any epithelial cells in the blood, despite the PET-CT showed multiple metastases in liver, bones, and lung, but she showed very high numbers of circulating stem cells. So we assume that due to this long course of disease, the tumor cells are so dedifferentiated that they do not longer express EpCAM, but the tumor stem cells can still be detected in a high number. And in this case here, again, patient with an inoperable peritoneal cancer. She had cycles of neoadjuvant chemotherapy with carboplatin and paclitaxel, and now she is under therapy with niraparib. And we only monitored her under this niraparib therapy. The patient had all the time very low and constant levels of epithelial cells, but stemtrac now shows a continuous increase in stem cells to a very high level, and this indicates that the disease is worsening and the clinical condition is also worsening. So here, stemtrac really reveals cells which may no longer express the epithelial antigen. Do you have any questions with these cases?
You showed us very clearly the good correlation in those patients who have a risk for recurrence. There's a correlation between CTCs and cancer stem cells, but there's a difference and a closer correlation with stem cells in the metastatic patients.
In the more advanced patients, yes, that's correct. This is now an answer when we recommend the stemtrac assay. This is, for example, like I showed in one of the previous cases, when the epithelial cells increase massively, although there is still complete remission, to confirm that this increase is due to cells with growth potential. Sometimes, as I also showed, numbers of CTCs are low or undetectable, but the clinic indicates disease progression. Then the stem cells correlate better with disease. And in some cases, the number of CTCs remains constant after the end of therapy and then suddenly drops drastically. This correlates with the self-seeding theory, which has been forwarded by Kim et al., who have shown that cells can re-enter tumors or metastases, and then they will disappear from the peripheral blood. And in cases of brain tumors or sarcomas where no CTCs are detectable, for therapy monitoring, we can try to look for stem cells. After completion of therapy of a primary tumor, we can assess the remaining tumor load for their risk of metastasis due to cells which can be induced to proliferation, the cancer stem cells. We can also perform chemosensitivity testing on these circulating tumor cells, and I'll show how we proceed here. We can show the response or lack of response to cytotoxic substances on the living circulating tumor cells. The cytotoxic substances can be conventional chemotherapeutic substances or also natural substances. And the substances can be tested in different concentrations, combinations, or even under hypothermia. And here is an example how a cell in a control population does not die at all, but under substance 1, there is an increasing cell death during time. And this can also be shown for substance 2 and substance 3. And this is a video which I would like to show, where you can look at this cell here, how it continuously dies, whereas the cell below remains alive. And I would like to point out this cell here, how it dies over time and even releases the nucleic acid of the nucleus, whereas this cell up here remains alive. So we can distinguish between the dying cells and the cells alive. The interpretations are given as a percentage of dead CTCs with the stained nucleus from all CTCs. And if there is only 10% death, the drug is ineffective. 10 to 50%, we call it a marginal efficiency, and more than 50% is a good response to the drug. And you can see this in the upper panel here with the different substances and how the cells respond to these substances. When would we recommend testing for optimization of therapy? This can be done after the initial diagnosis, before therapy is initiated, or in the metastatic situation before starting a new therapy, and in case of progression of the disease under treatment. Some examples shown here where we tested several substances and could show that docetaxel and doxorubicin were both effective. Paclitaxel and epirubicin were not effective. The patient was treated with 4 times doxorubicin and cyclophosphamide and subsequently with docetaxel due to our results. And it was shown that there was a nice decrease under this treatment. The patient even had a pathological complete response, and she's now under treatment with tamoxifen, where the cell numbers remain relatively stable and circulating stem cells even decrease to below detectability. Another patient where breast cancer surgery was performed before therapy, and the adjuvant therapy was also designed according to our results. And epirubicin, you can see, is quite effective. Docetaxel would have been more effective, but the guidelines recommend paclitaxel. She received this treatment. Her cell numbers were reduced to very low level, and the patient now remains in remission. And another patient with metastatic pancreatic cancer, we tested for paclitaxel and gemcitabine, which was recommended. The patient was treated. She showed a significant decrease in circulating tumor cells and a very good clinical response, which is shown here. The lesion was decreased in detectability after 3 cycles of chemotherapy. So now the recommendations for timing of blood samples. If you want to know whether the neoadjuvant chemotherapy works on the circulating cells, you should test before and after the end of neoadjuvant chemotherapy. And this mainly or often is before surgery. And then you can see, if you test 3 to 6 weeks after surgery, whether cells have been released by surgery. If there is chemotherapy given adjuvantly, you can see after each 2 to 3 weeks after giving the chemotherapy, whether it has reduced the circulating cells. And you can also test after completion of therapy, also recommend 2 to 3 to 6 weeks after the end of therapy. During hormone or maintenance therapy, blood sampling is possible at any time, and it's also at any time during the therapy-free period. So this is our recommendations, but we can talk and you can ask questions when we think it's best in your individual patient. So thank you for your attention, and we try to answer all your questions, and you can send an email to our laboratory or to maintrac.com.
Thank you so much, Professor Pachmann, for this presentation. Gives a lot of thoughts, hopefully, some of the clinical pearls that I was talking about, which you can use. But please don't hesitate to write or to call for any further questions. We'll come back for another forum in 3 months' time.
Yes.
And we hope to see you all there. Thank you, Professor Pachmann.
Thank you all.